Good morning, everyone. Welcome to day 2 of our workshop entitled Navigating Infodemics and Building Trust During Public Health Emergencies. I'm Dr. Howard Koh, and I have the honor of serving as the chair of the workshop planning committee and also moderating yesterday and today. Just to remind you, this workshop has been organized by the National Academies of Sciences, Engineering, and Medicine and is sponsored by the CDC Office of Readiness and Response. Let me start by thanking the moderators and speakers that made yesterday so special. On day 1 of the workshop yesterday, we reviewed the historic and global context of this pandemic era, and then started in talking about what an infodemic is. To remind you, as there are many definitions, the planning committee put forth a guiding definition for the purposes of this workshop. According to our planning committee, an infodemic is, quote, the rapid spread of large amounts of sometimes conflicting or inaccurate information that can impede the ability of individuals, communities, and authorities to protect health and effectively respond in a crisis. And also, just to refresh your memory, public health emergencies are defined as situations whose scale, timing, or unpredictability threatens to overwhelm routine public health capabilities. The workshop yesterday explored the information ecosystem and how it evolves during a public health emergency like COVID-19 or a natural disaster. We had discussions about interventions and approaches in preparation for and response to an infodemic. And we closed out the day talking about the capacities, capabilities, partnerships, and collaborations across sectors and the levels of the systems needed to effectively implement these interventions. So today, on day 2, we will start the workshop with a plenary session and 2 presentations. In the first, Dr. Sandra Quinn will provide an overview of both the 2022 National Academies workshop entitled Building Public Trust in Public Health Emergency Preparedness and Response Science, as well as the expert meeting hosted by the Standing Committee for the CDC Center for Preparedness and Response on that topic. And then in the second presentation, Dr. Tara Kirk and Annie Sundelson will present the findings of a commission paper on infodemic management approaches before, during, and after the COVID-19 pandemic. After the plenary, we will hear from panels using the frame of the socio-ecological model to examine strategies to intervene, starting at the institutional or structural levels of the system. After that, the next panel will look at the community level, identifying interventions to support community resilience with a focus on diverse or marginalized communities. And then the third panel will examine strategies and interventions at the information and individual levels. And then our final session today will be a roundtable discussion that I will chair, in which we all looked at the future and ask, what does a functioning, proactive, adaptable learning system for managing the information ecosystem look like during quiet times, and of course, during the high stress times of a public health emergency? As a reminder, please feel free to engage with the panelists and all of us by offering questions for Q&A. So we look forward to a really excellent day 2 today, and I thank you all for coming back and joining us in this very important discussion about the future of public health. And with that, I am very pleased to hand this over to my colleague, Dr. Sandra Quinn of the University of Maryland School of Public Health.
Thank you, Dr. Koh. And Matt, let's see some slides. I'm on behalf of the planning committee for our workshop on building public trust in public health emergency preparedness and response science, called PHEPR science. I'm happy to share what we discussed and learned. Next slide. The workshops were held a year ago now, and we were really focused on the building knowledge of and trust in PHEPR science enterprise. And we describe that trust, or define as trust in the individuals and the institutions that implement, that create the science, as well as trust in the processes by which they do that. Next, please. In day one, we examined the issues of trust from a couple perspectives. We talked about some of the determinants of trust, including some of the historical roots of mistrust, the challenges defining and measuring trust, and what does it mean to be a trusted messenger. We talked and assessed really what's the state of knowledge and attitudes toward PHEPR practice and science. And then finally, we explored some of the causes of diminished trust in PHEPR practice and science, from mistrust, mis or disinformation, the poor communication and difficulties translating our science. Certainly, we've seen the political narratives play a role in this, as well as the broader demographic factors and the differences amongst communities across the country. Next, please. On day two, we focused on what are some of the strategies we might use to rebuild and maintain trust. And some of those that were a heavy focus were community engagement, building it, sustaining it, and bringing them into decision-making. How do we go about improving the translation and the communication of PHEPR science information? We talked a lot about the information environment, as you have been doing. And we recognize that we need to make some changes in the public health infrastructure, including training the workforce in crisis and emergency risk communication, community engagement, and bringing on key staff and supporting those staff, such as community health workers. Next, please. We had another meeting that really then further explored the actions, and we worked with Deloitte's 4 signals that they believe contribute to greater trust: humanity, transparency, capability, and reliability. Next. And I'm going to just hit some of the highlights. Under humanity, the real essential core of this is building relationships with the diverse, very diverse communities that we serve. And in times of an emergency, building it with empathy and compassion and care, given the toll that these emergencies take. We recognize that if we didn't have them, we need to build, or at best revitalize, the community networks that enable us to have bi-direction discussions for sharing information and for decision-making. But in order to do that, we're going to need to demonstrate our listening. We're going to need to be able to explain issues that are often complex and relate this to the communities and their experiences. Humanity also means recognizing there are leaders in these communities, formal and informal, such as community health workers and other messengers, that will be vital to framing our message and disseminating our message. And finally, what do we do and how do we integrate all of what we know from the psychology of human decision-making into this process? Next, please. Capability. One of the things that is really clear coming out of, or hopefully at some point out of the pandemic, is that we need to do more to establish both the infrastructure and training for public health agencies to really be able to meet communities where they are. So, for example, training in community engagement, building trust. We are really cognizant of the need to collaborate with agencies beyond our traditional public health agencies and across sectors, both on crafting messages and communication that are salient and respectful of the needs and concerns of communities, but also disseminating those messages. We'd like to see more coordination to facilitate some unified communication, and that could be the subject of a workshop itself. Crafting messages in the time frame we need to do it in an emergency. How do we best do that and build the capacity without some of our traditional review processes? And how do we pre-build the networks that expand sort of our capacity at the time of any type of an emergency. Reliability is another key component of trust, and one of the critical factors in a pandemic and other emergencies is uncertainty. We don't know much, information changes rapidly, and we need to talk about how do we do a better job of preparing communities for that uncertainty. We want to really, and the group talked about how do we focus on relationships with the practitioners who are implementing the science, that understanding the technical side of the science may not be as important as building those trusting relationships with trained communicators of the science, and then building relationships across agencies at all levels. Next, please. The last dimension of trust is transparency. And this sort of goes with the initial humility and humanity we talked about. How do we begin to involve partners and communities early in decision-making? How do we make sure that they know and recognize and begin to trust who our public health officials are and spokespersons are? That we need to think about how might we provide sufficient detail in official statements that help us acknowledge counter narratives, and provide data in a timely way. Part of that providing in a timely way is also being consistent so the public know when we will be coming back to them with new information as it changes. And finally, one of the topics of discussion in our follow-on workshop and other workshops the Academies has held is how do we ensure the independence of scientists and public health officials so that their communication and their practice and policies can really be based on science and free from political pressure. And that is a critical part of transparency and building trust. With that said, I'd like to thank you, and I'd like to turn it over to Tara Kirk.
Well, hi, thanks so much. It's my great pleasure to introduce Annie Sendelson, my PhD student at the Johns Hopkins Bloomberg School of Public Health, who co-led our work on the commission paper for the National Academies on approaches to managing infodemics. The work was based on original research supported by the Centers for Disease Control and Prevention. And today, Annie will walk you through the range of tools and approaches that have been developed or are in development to improve trust and communication and combat mis and disinformation during an infodemic. And our look at these interventions has led us to develop a modified social ecological model that will be used to organize the rest of the day. And so, I think we're eager to see what has been developed. So I will pass it over to Annie so we have more time for questions and discussion afterward. Take it away, Annie.
Thank you so much for the introduction, Tara. So again, my name is Annie. I'm going to be speaking to you about the paper that was commissioned for this workshop, the aim of which, as Tara said, was to characterize infodemic management strategies at the international, national, state, and local levels. Next slide, please. So just to give you a brief overview of the methods that we used for this paper, we actually leveraged a database of infodemic management tools and approaches that was developed for a project funded by CDC. All of the tools and approaches in the database were drawn from academic literature, gray literature, state and local health department websites, as well as interviews with key informants. And the academic literature was also used to summarize evidence for the effectiveness of different approaches, as well as their strengths and limitations. And I'll be talking about those very briefly. Next slide, please. So as Tara mentioned, we're using a modified social ecological model to organize infodemic management tools and approaches. And there are 4 levels to our model. So the first level down in green is the information level, and this level included tools and approaches designed to tackle information itself, including accurate information, inaccurate information, as well as lack of information or information voids. The second level is our individual level, and that contained tools and approaches designed to enhance individual level resiliency to mis and disinformation. The third level contained tools and approaches that targeted relationships as well as communication at the interpersonal and community level. And then the fourth and final level contained tools and approaches for managing the infodemic at the institutional or structural level. I'm going to walk you through each of these levels briefly, give you an example of the different categories of tools and approaches that are on the right of this slide here, as well as provide some examples of the tools and approaches. And I'll also touch briefly on the evaluation for the effectiveness of those different tools. Next slide, please. Okay, so the first level, again, we're starting with the information level. If you are curious about where we are in the social ecological model, you can look at the bottom right of the screen. So we're in the lower level, or that green circle. So this level contained 5 categories of tools and approaches. The first were tools or approaches for amplifying factual information. And a great example of one of these tools is the Dear Pandemic project, which was established by a group of female researchers who refer to themselves as those nerdy girls. You may have heard of them. And Dear Pandemic was an effort to disseminate and amplify factual information on social media channels like Instagram and Facebook in a way that was easily accessible and understandable. The next category of tools were those for filling information voids. And a good example of this is the partnership between Google and the World Health Organization. So they actually partnered starting at the beginning of the pandemic to create an organized search results panel on Google so that users of Google who were searching for information about COVID-19 were directed to credible information from authoritative sources like WHO, CDC, state and local health departments. And so this is an example of an SEO tool, or a search engine optimization tool, because it's using a search engine to fill information voids. The next category in this level were tools to debunk false information or refute false information. Good example of one of these tools is the Coronavirus Facts Alliance, which is a website that contains a fact-checked or a database of fact-checked rumors as well as misinformation specifically about COVID-19. And then the fourth category contained information tracking tools. I'm sure a lot of you are familiar with WHO's EARS platform, which is a social listening platform that allows users to gain an understanding of how individuals are talking about COVID-19 on social media as well as other publicly available channels. And then finally, the last category in this level were verification, credibility, and detection tools. So tools designed to verify information, detect false information, or rate the credibility or biases of sources of information. And an example of one of these tools is called Botometer, which is an online tool that helps users discern whether a Twitter account that they're looking at is likely to be a bot or a real person. And so in terms of evaluation of these tools, there is evidence that many of these categories of tools are effective. So for example, there is substantial evidence that false information can be debunked successfully or refuted. However, I do want to point out that the way people process and absorb information is dictated largely by cognitive biases and heuristics, one of which is called confirmation bias, which I think was mentioned in yesterday's meetings. But what this essentially means is that if individuals are provided with information that does not conform to pre-existing beliefs or their worldview, they're unlikely to accept that information, even if it is factual. So unfortunately, this and other biases really limit the effectiveness of some of these approaches. And this is kind of an ongoing and unresolved issue so far. Next slide, please. So the second level, as you can see, we're in the blue level here of the social ecological model, is our individual level. And this contained 2 categories of tools and approaches. The first were those designed to enhance information literacy, including science or health literacy, digital or media literacy, as well as information literacy, broadly speaking. And a good example of a information literacy tool that sought to enhance general information literacy is called the CRAP test. You may have heard of it. It's just a tool that anyone can use to evaluate a single piece of information based on its currency, relevancy, authority, accuracy, and purpose. And then the second category of tools were pre-bunking or inoculation tools. I think this was discussed a bit in yesterday's meetings as well, but these are designed essentially to confer resistance to mis or disinformation. And so there are kind of two strategies to use to pre-bunk or inoculate. The first is to inoculate against anticipated false information, so actual false content that we anticipate will occur. Van der Linden et al. Has a really good example of this in the paper that's cited at the bottom of the slide about misinformation about climate change, specifically, if you're interested. And then the other category is to inoculate against common tactics of deception. So instead of content itself, against those kind of manipulative tactics that are used in mis and disinformation campaigns. And an example of this is the Go Viral game, which was created by WHO and the UK Cabinet Office. And it allows users to assume the role of online manipulators and learn how to create viral false content, which theoretically then confers some psychological resistance to those future mis and disinformation campaigns that one might encounter. So like in the information level approaches on the previous slide, there is evidence for the effectiveness of these approaches as well. So there is evidence that information literacy interventions can help people think more critically about the information they consume. There's also a growing body of evidence that suggests pre-bunking and inoculation can actually confer that psychological resistance against mis and disinformation. However, I think it should be pointed out that in order for these approaches to have wide real-world impact, people are going to have to agree to be either inoculated or to undergo some form of information literacy training. And this may be difficult given the politicization of public health as well as health information in general. Next slide, please. All right, so our third level were the approaches at the interpersonal or community level. This contained two categories of tools. The first was resources for public health communicators, and this included resources for both traditional public health communicators and non-traditional public health communicators. And when I say traditional public health communicators, I mean physicians, nurses, healthcare workers, those working in local or state public health departments. And an example of one of these resources is Public Health Communication Collaborative's collection of resources that they have online. This includes messaging guidance, tips for communication, all of which allow public health communicators to convey information in a more effective way that resonates with target audiences. And then an example of a resource for non-traditional public health communicators is the COVID-19 Misinformation Toolkit for Kids. It's actually a Canadian toolkit that is a guide for parents for how to talk about COVID-19, as well as misinformation about COVID-19 with their children. And then some of the other tools in this category targeted school teachers, faith leaders, school administrators, so those kinds of communicators. The second category in this level were community engagement approaches. So we have heard both today and yesterday about the importance of community engagement. A lot of these worked by identifying and utilizing trusted messengers. Vaccinate Your Family's Squad program is an example of this. It essentially trains community vaccine advocates so that people can go out in their communities, provide accurate information about vaccines and their benefits. And a lot of these approaches also targeted traditionally hard to reach, vulnerable or marginalized communities. A good example of one of these approaches is Life Chair Health, which is a program designed to reduce the life expectancy gap among Black men in the US. And it does so by training barbers to have conversations with their clients about health. And in the COVID-19 pandemic, they kind of shifted to general health conversations towards conversations about COVID-19 mitigation measures like masking and vaccination. And so these approaches really touch on one of the most important components of and contributors to mis and disinformation and infodemics broadly, which is lack of trust. So by leveraging community messengers and by establishing trust and understanding community information needs, these approaches offer a really promising way to overcome barriers to communication, such as lack of trust that are widespread in the US and elsewhere. I do think it should be noted that, and this was also discussed yesterday, that community engagement really should not be a last minute or short-term approach. So communities really, to actually establish trust with them, they need to be engaged pre-crisis as well as during a crisis. And those relationships really need to be maintained so that they can then be used during a crisis. Next slide, please. All right, the fourth and final level were our institutional or structural level approaches. So this had 6 different categories of tools or approaches. The first were those for journalists and fact checkers. A great example of this is the Global Health Crisis Reporting Forum, which was a project established during COVID-19 to provide journalists with factual information about COVID, as well as tips for how to cover a global health crisis as it emerged. Another category of tools in this level were those designed to manage academic or scientific literature. An example of this is called something called the COVID Contents Initiative, which was actually an Italian initiative designed by the Italian National Institutes of Health, where a group of researchers got together and sifted through emerging scientific literature about COVID in both peer-reviewed articles as well as preprints, and then provided those summaries to public health communicators as well as physicians so that they themselves did not have to sift through the massive amount of emerging literature. We also had resources for infodemic managers in this category. So those working on infodemic management at high levels of public health or state health departments, or those working for companies even to try to manage the information environment. A great example of this is the World Health Organization's Infodemic Manager Training Program, which is an online training program that teaches individuals how to become more effective managers of infodemics. And then we also had resources for those involved in infodemic research or infodemiology. So the Mercury Project is a funding mechanism for researchers that are doing research on mis and disinformation. We also included social media regulation in this level. So this included all of the policies that various social media platforms instituted to regulate content on their platforms. So an example is Meta's COVID-19 related policies, where they limited the spread of false information as well as removed posts or accounts that were propagating false information. And then finally, we had some policy and legislative tools and approaches. An example is the Health Misinformation Act of the US, which was proposed by Senator Klobuchar. It was designed to reform Section 230 of the Communications Decency Act in order to hold social media platforms liable for using their algorithms to spread false information during public health emergencies. So these approaches are really promising in that they offer a more supply-side approach to tackle mis and disinformation. And this may be more effective than tackling mis or disinformation once it's already emerged, because we know from experience that it is really difficult to correct false beliefs once they have been adopted. However, I think there are some important consequences of some of these tools that should be kept in mind as well. For example, a social media regulation approach is to delete accounts or delete people's posts that are propagating false information. This, unfortunately, could backfire and actually increase conspiratorial beliefs among people whose posts are being deleted, because it could verify to them that some plot is afoot, right? That their accounts are being deleted for some reason, some government conspiracy theory. And I also think it should be pointed out that it is really difficult, particularly in the US, to pass legislation on mis and disinformation, given just the tension between protecting civil liberties and protecting public health. And that is kind of an ongoing issue in the US currently that has made it difficult to pass legislation. Next slide, please. Okay, and then finally, I just want to wrap it up by bringing it back to the entire model, again, that social ecological model. So I've been talking about these different levels individually, but I want to emphasize that these are really nested, intersecting levels, and that a coherent and cohesive approach to managing the infodemic will really pull tools and approaches from each different level. Thank you so much for your time, and I look forward to the discussion.
Thank you so much, Sandra, Tara, and Annie. Those are excellent. And first, Sandra, thank you for chairing that committee and putting forward such a very important report on trust and having that workshop to go through those recommendations and talk about how to make them actionable. And then Tara and Annie, that's a very thorough, very impressive presentation. I love the way it's organized through those levels, and it really is organized so well. So we could have many questions. We have only about 10-15 minutes here. First one, of all the recommendations that have been put forward, which ones have been most heavily evaluated for outcomes? Are there a couple that you think could be viewed as standard practice now, or are they all suggestions that are in evolution? I don't know if anybody wants to react to that.
I can talk a little bit about the evidence base, just because we looked at that for the different tools that we had. I think the information level approaches have really been evaluated most experimentally. So debunking, as well as some of those individual level approaches, so pre-bunking and inoculation, have really been tested experimentally, but I think it's a little bit difficult to translate that into the real world because those experiments are so kind of confined to experimental conditions. But I think those are the ones that have really the most robust evidence associated with them.
Okay. I don't know if Tara or
Yeah, another part of the project that helped support this work was us working to do interviews with people who are working on the ground and actually putting these efforts into practice. And from what we hear from practitioners, that community engagement piece is really the most important piece, is what really moves groups towards trust, as Sandra was talking about. And so, although there probably aren't as many experimental studies, I think that the evidence from work on the ground has really shown that is one of the key pieces.
Okay, that's great. And Sandra, you mentioned several times the importance of community health workers. Do you want to say more about that and how that's all going in terms of future training and outreach?
Sure, and I think it ties right back to what Annie and Tara have talked about here. Is we've seen it in Communivax and CommuniHealth studies and multiple other studies, particularly during the pandemic, about the importance of community health workers and building that trust and being also the conduit for public health officials to know what communities are thinking and worried about, et cetera. And we also know that, and working with communities through community health workers also gives us the opportunity to bring many of the tools that Annie just described, particularly those associated with the individual level and the community level tools, because people are hungry. That's been our experience on the ground. People are hungry to learn how to make sense of this barrage of misinformation, credible misinformation and disinformation. So I think we're really talking about the need for significant training for both community health workers, but also really looking at how do we ensure that our public health practitioners really have the kind of training. This is a complexity that is new to us in public health, and it's going to require a significant building of training and capacity kind of at all levels.
Okay, good points. And maybe I can add in personally and professionally. I've watched as community health workers have been hired and then let go through the pandemic without the understanding that we need them throughout the whole multi-year challenge. And I think that's frustrating state and local health leaders because we need these professionals interacting with the community day in and day out, and especially in quiet times like this, as we've stressed all through the last 2 days. So thank you. And there's some questions from several of our colleagues about scaling and taking some of these interventions and making them larger. Can the three of you comment about any of that with respect to the themes you put forward?
Well, I think the scale question is probably well, there are many difficult questions in this topic area, but the scale question is one of the really hard ones, right? Not only we can prove that maybe it works in a small context, but the amount of effort needed to sort of push these things forward, the personal touch, scaling, the amount, I think that we need to sort of come to grips with the idea that this can't be done on the cheap, and that, we do need to commit resources to that, this effort, if we want to scale up and make these interventions more applicable across larger groups. But I want to emphasize, it's hard. The other problem with making them trying to make them applicable across large groups is that it takes that personal touch where we need to focus and target on the needs of certain subpopulation. It takes that sort of granularity away, and I think that makes it difficult for people to sort of have those trusted conversations when we've taken away the nuance there to make it broader scale.
Right, excellent points. Maybe just to help the everyday state and local health professional, is it possible to have some kind of toolkit that's summarizing all the themes from these two presentations and make that available to state and local leaders for training purposes and then for implementation through a crisis? Is that an outcome we're all working towards somehow?
Well, so our project, the last few months of it are dedicated to creating such a toolkit. So yes, one is on the way. We are creating we're creating also an online database for with the 350 or greater than 350 tools that Annie and colleagues collected, so that it's searchable. Not so much so that people can say, like, this tool, I'm going to use it, but to see the examples of the types of tools, because we know such a database would be out of date as soon as it was published, but to see the examples so that people don't have to start from scratch is one of the goals of our project, as well as sort of other tools to help sort of get people moving on that process, not to just say, like, here's a database, do what you want with it, to actually help people sort of make those steps along the way. So that's in process, but not quite out yet.
Great, that'd be a great outcome. I've asked repeatedly, as our planning committee has met, if there's more attention to the fact that study after study on trust show that the most trusted professionals through a health crisis are one's own direct care providers, doctors, nurses, social workers in the healthcare setting. I think one of our speakers said that yesterday. Can anybody comment on that? And are there more efforts to work with the healthcare sector? Because these are the folks that are being in direct contact with the people we're trying to reach. How do we do that better? And knowing that these are very overwhelmed professionals too. So I don't know if any of the three of you want to comment on that.
I'll jump in here, Dr. Coe. It's interesting because that piece of data has remained consistent for years.
Right. People
say it's their doctor, their healthcare provider, and yet the reality is we don't often see them. Many of us don't often see them. But I do think that, and this has been one of the things that I think is doable, is at the organizational level, for instance, in Maryland, I worked with the Department of Health and their primary care division. So through the pandemic, as we were getting ready to roll out the vaccines and the rollout, we did a number of sessions on how to talk to their patients about the vaccines, about the trials, about the concerns we knew people had. You know, what does mRNA do to your genetic makeup, et cetera. And I did some of those as well with Blue Cross Blue Shield, Care First, some large organizations. So I think there can be more of that, and there's certainly tools to help providers, and CDC has done a lot of this. But I think you go back to what you said. These are really busy people with limited time. So how do we extend to using community health workers, training other staff in the office of, of physicians? It does not have to be the physician necessarily. So I think it's really looking at training a cadre of people. And then, as you really very well put, is we can't let them go away when the emergency goes away. That is one way we diminish trust. And it's happening right now when, hospital and health systems are not willing to come out to barbershops and community sites like they were a year ago.
Thank you for your comments. Looks like Maryland's a model, and I personally would love to hear more about how the healthcare system, hospitals, clinics could be connected with the public health system and the community in a more strong way. I mean, we've all seen the obvious link through the pandemic. Everybody knows that now. So if we can work even more closely together, I think that'd be great. So we only have 3 minutes left, maybe time for a major takeaway or two from each of the three of you. You presented a lot of information, but if you had a single takeaway or two, just literally in a minute, how would you leave us here? Tara, you want to start?
Sure. I think that, we've seen that there are a lot of interventions out there. And Annie, I hope this is not your takeaway, but I think that these interventions, they're all have some hints of where we can go and what we need to do, but used by themselves, unfortunately, I think that they are not quite enough to get us there. And so I think thinking about these constellation of imperfect interventions, I think, is some of the ways that we might think about moving forward. That some interventions may not work best with some populations, they may work better with others. And so, thinking about sort of across that, the model that we developed, I think is the way to sort of move forward and trying to help improve resilience and improve trust, in a variety of different ways. I think that's the key point.
Great, very, very well said. Annie, one final takeaway from you?
Tara, you stole my comment a little bit, but yeah, I just think, as I said, the infodemics are complex and the information environment is complex, and it gets even more complex during a crisis or a public health emergency. And I think tools from all of those levels really need to be pulled to make a kind of cohesive strategy that's effective.
Great. And Sandra, you have the last word.
So I want to tie what Tara and Annie presented back to the point about building capacity and training. And I think that the challenges we're grappling with and the opportunities we have right now to address them mean that we really need to think hard about what public health training looks like today, who our workforce is, and how do we prepare them to work in this space.
Okay, how excellent. All three of you were great. This is a fantastic opening plenary. So thanks to the three of you for setting us up perfectly for the rest of the day. And so now I'm going to turn this over to my good friend Gretchen Michael of HHS, and she'll be moderating the next session on interventions at the institutional and structural level. So welcome, Gretchen.